So in the concept of intracranial regulation, one of the exemplars is stroke, and we're going to talk more about that exemplar in this little mini PowerPoint. In this PowerPoint, we'll identify the risk factors for strokes and related measures for prevention. Another outcome is discuss general management of the client experiencing a stroke, explain the principles of nursing management for the care of the client with a stroke, identify essential elements for family education and preparation for home care of the client experiencing a stroke, and lastly, use the nursing process as a framework for care of the client with a stroke. Cerebrovascular disorders are the functional abnormality of the CNS, the central nervous system, that occurs when blood supply to the brain is disrupted. The cerebrovascular accident, which is also CVA, also known as a stroke, and that's what I'll call it from now on, is the primary cerebrovascular disorder. It's the fifth leading cause of death in the United States, and it is the leading cause of serious long-term disability in the US. Most people that have strokes don't die from a stroke unless it is a large amount of blood supply that's cut off to the brain. Usually they end up with deficits, and those deficits can range anywhere from a little speech abnormality to total paralysis on one side of the body to someone requiring total patient care. So it is on a continuum, and there's a huge financial impact, not just to individuals, but also to our healthcare systems. Clients who have had strokes are in and out of our hospitals, our healthcare system, with complications that are usually a result of their strokes. So let's talk about prevention, stroke prevention. We've talked about intracranial regulation risk factors, and most of this is going to be a review from the first PowerPoint that you listened to in the overall concept, but specific to the exemplar of stroke, there are some non-modifiable risk factors. Age, gender, and ethnicity. So people that are over age 55, males, African Americans, these folks are more at risk for having a stroke. And as far as modifiable risk factors go, hypertension is the primary modifiable risk factor. And if you have a male who is African American and has a history of hypertension, they're at even greater risk. And we do know research shows that there is a high prominence of hypertension in the African American culture. So the next modifiable risk factors are cardiovascular disease. So atrial fibrillation is a rhythm disorder of the heart. It's where those top chambers of the heart, the atrium, don't contract in a normal manner. So they just quiver and they don't move the blood forward into the ventricles. So if they're not moving that blood forward, a clot can form in that atrium. And if one of those clots breaks off and gets loose and travels, the first place it's going to travel to is the brain, and that will cause a stroke. Similarly, with valvular disorders, you have the heart valves that aren't opening and closing correctly, so therefore that blood is not getting pushed forward, it's more stagnant. And again, if it breaks off, it's going to go to the brain and cause a stroke. Elevated cholesterol is when there's too much circulating cholesterol in the body, and that cholesterol will stick to the lining of the arteries, and eventually it'll become part of the lining, and that's called arteriosclerosis or atherosclerosis, which causes those arteries to become narrower, more narrow. And if there is a clot in the heart like that, it can cause a heart attack. But if you have that clot or because the vessel is so narrow, if the blood flow is restricted in the carotid arteries or the brain, then it can lead to a stroke. Elevated hematocrit makes the blood thicker, so that, again, the blood's not flowing normally, can cause a stroke. Obesity, sedentary lifestyle, these are all non-modifiable risk factors. Diabetes, especially individuals who don't have their glucose regulated well, they can be at more risk for a stroke. Sleep apnea, those individuals that have issues with sleep apnea are at higher risk. And then oral contraceptive use. I actually, my college roommate had a stroke and she had been on oral contraceptive and she smoked. Combining those two together can increase your risk for stroke. Alcohol abuse, and then periodontal disease. Periodontal disease, the reason that can cause stroke is because of the infection and different pieces of plaque. The infection can form a clot and that can cause the stroke. So hope you understand here that it again goes back to that intracranial regulation concept where all of these factors can impact the blood flow to the brain and then cause the stroke. Transient ischemic attacks, or TIA, are warning of impending stroke. So 15% of all strokes are preceded by TIAs. Some people have a lot of mini TIAs and they don't even realize it. My uncle, who passed away this past summer, had several little TIAs and was not diagnosed with these. With these, individuals usually have a sudden loss of motor, sensory, or visual function. So something does not appear right with these individuals. It doesn't have to be all of those functions, but it depends on where that little temporary impairment of blood flow in the brain is. It lasts less than an hour. When it is done, typically the individuals will the function will return. When these individuals get to the ER, it's real important for them to get an initial diagnostic test of a CT to see what's going on, to rule out other things such as a ischemic or hemorrhagic stroke. And we'll be talking about that in the next couple slides. So this chart is taken right from your textbook, and it is a good comparison of the two major types of strokes. We'll be looking very closely at the ischemic stroke in this lecture and in Wellness 1. Hemorrhagic stroke will be covered in detail in Wellness 4. But as you can see here in the chart, most strokes are ischemic. 87% of all strokes are ischemic. The main presenting symptom that you will see with an individual who is experiencing a stroke will be numbness or weakness of the face, arm, or leg, especially on one side of the body. And we talked about that in the last PowerPoint of the intracranial regulation concept, where if the right side of the brain is affected, then the individual will display a deficit in the left side of the body. And similarly, if the left side of the brain is affected, then that deficit will show up in the right side. It can take many months for people to recover from a stroke. And we're going to be talking in great detail about recovery and what that looks like and how we can assist our clients with strokes. But the difference when individuals come to the emergency room, the treatment is based on which of these strokes is occurring. And the primary diagnostic test that is done when people get to the ER is the CT scan, because it determines the therapy. It determines how this patient is going to be managed in the emergency room. So the book tells you that when a client gets to the emergency room, a CT scan should be done within 25 minutes or less, because the type of treatment is going to be different depending on whether it's ischemic or hemorrhagic. The hemorrhagic type is oftentimes fatal. It starts off, or the main presenting symptom is a intense exploding headache. decreased level of consciousness. Dr. Madden told a story about her husband who actually experienced one of these after sneezing, and he heard a pop. He had this exploding headache, and he ended up having this subarachnoid hemorrhage, which he ended up being fine. But I just want you to know the difference between these two strokes. In this class, we will focus on ischemic stroke. An ischemic stroke is the disruption of the blood supply caused by an obstruction, whether it's a thrombus or an embolism. And it causes infarction of the brain tissue. It causes death of the brain tissue. And you can see in that small box below the brain, you can see the plaque has built up inside that artery, and it's made it narrow. And a little embolus is broken off from somewhere and has traveled to this narrowing area. And what happens is the body sees it as an insult, and platelets rush to that site and cause more of a clot. Well, if you look up into the picture of the brain, you can see that area that has suffered disruption of the blood supply, that tissue around it, whatever tissue is downstream of that area, is going to be affected. So sometimes there is some secondary or collateral blood vessels that can kind of jump in and perfuse the brain. But if that perfusion is affected, if there's a loss of blood flow, if the blood flow is not oxygenating and perfusing that part of the brain, then that whatever part of that brain what it's responsible for will be the deficit that we will see in our clients. I like the term brain attack because I think it helps bring home. It's just like a heart attack. So in the heart, when there's a clot that lodges in a vessel and the heart muscle doesn't get oxygenated, doesn't get perfused, that sudden loss of the blood supply is a heart attack. Well, in the brain, it's the same type thing. You have a infarction of the brain tissue. The tissue is dying or is dead, and then there's a loss of function because of that disruption of the blood supply to that part of the brain. So what's it going to look like when a client of yours has an ischemic stroke? What are the clinical manifestations? That is really going to depend on the location and the size of the affected area. We talked a little bit ago that the first thing that we typically see is numbness or weakness of the face, arm, or legs on one side of the body. Flaccid paralysis means, if their arm is impacted, their arm will just go limp. Arm kind of hangs limp. They may have a decrease of deep tendon reflexes. They'll have confusion or change in mental status. They might have trouble speaking or understanding speech. If it is a motor deficit, they might have difficulty in walking. They might have dizziness or loss of balance or coordination. Sometimes the clients will have sudden or severe headaches. Typically, that's going to be more with a hemorrhagic stroke, but it can happen with an ischemic stroke. And then they also can have perceptual disturbances. So that means they're not able to tell distances or how far apart things are. You need to know and understand these terms as they relate to the exemplar of strokes. Hemiplegia is paralysis of one side of the body, and that can be the face, the arm, the leg, or all of the above. And again, remember, that's the opposite side from the damage in the brain. Hemiparesis is weakness of one side of the body, opposite side from the damage in the brain. Dysarthria is difficulty in articulating or forming words. Aphasia is inability to express oneself or to understand language. And there's 3 different types of aphasia. The first one I have listed here is expressive aphasia. That is the inability to express oneself. Receptive aphasia is inability to understand what someone else is saying. And global aphasia is the combination of both receptive and expressive. And the next slide, I have put in a little table to demonstrates the brain area that's involved for each of the different aphasias. Apraxia is a disorder of the brain in which the client is unable to perform tasks or movements when they're asked to. The request or command is understood. They're willing to perform the tasks, and the muscles needed to perform those tasks are working properly, but they've learned those tasks before, but they're unable to perform them. Homonymous hemianopsia is when the client is unable to or unaware of persons or objects on the side of their body. So they're unaware of persons or objects on the side of their visual loss. This means they can't even see that side of their body. They have difficulty judging distances, and they neglect that one side of the body. Agnosis is loss of ability to recognize objects through a particular sensory system. So it could be visual, could be auditory, or it could be tactile. So this is a chart that reviews the type of aphasia. Remember again that aphasia is the inability to express oneself or to understand language. And if it is an expressive aphasia, if it's expressive speaking, the brain area that is involved is the inferior posterior frontal areas. If it is expressive writing, it's going to be just the posterior frontal areas. For receptive aphasia, if it's auditory, the brain area involves the temporal lobe, and if it's visual, it's the parietal and occipital area. There's a really good chart or table in the textbook on page 2012 that breaks up these neurologic deficits of strokes based on the deficit. So it breaks it up by visual, motor, and sensory and verbal, cognitive and emotional deficits. And it tells you what it is that client's going to look like and how that should impact your nursing interventions or how you educate clients. I would highly recommend you know that table on page 2012. So let's look at left versus right hemisphere strokes. On the left-hand side here, I've listed what you would anticipate a client looking like who has had a left hemisphere stroke. They will have paralysis or weakness. Again, that's hemiplegia and hemiparesis. Paralysis or weakness on the right side of the body. The opposite side has been affected. They will have a right visual field deficit. So remember what that means is, that doesn't mean they won't be able to see out of the right eye. What it means is they lose the right visual field of both eyes. So both eyes, they won't be able to see the right, out of the right visual field. So it's losing the right visual field of both eyes if they are having a left hemisphere stroke. Aphasia can take place, and that is the expressive, receptive, or global types. They will have altered intellectual ability and slow, cautious behavior. If the stroke happens on the right hemisphere, they'll have that hemiplegia or hemiparesis on the left side of the body. Their left visual field will be impacted. They'll have a left visual field deficit in both of those eyes. They will have inability to pay attention to spatial perceptual deficits, so they won't be able to tell how far away things are. They have more of a chance of being distracted, increased distractibility. They can have impulsive behavior and poor judgment, and lack of awareness of their deficits. The frontal lobe, remember, goes all the way across the front of the brain. So when the frontal lobe is affected in a stroke, the the deficit will occur in the learning. They'll have less of a learning capacity. They'll have memory or attention span deficit. They might be more forgetful or have issues with comprehension and lack of motivation. So preventative treatment is the best approach. We want to try to prevent strokes. We've talked about this in the high risk, or the risk factors slide. We want to encourage healthy lifestyles, encourage not smoking. We want individuals to exercise, eat a healthy diet, maintain a healthy weight, make sure their blood pressure is within normal limits. In a couple slides, I'll be talking about the carotid endarterectomy and the percutaneous treatment for carotid stenosis. A lot of times clients will be on anticoagulant therapy like warfarin if they have AFib, that's a blood thinner. And being on this anticoagulant therapy or the blood thinners can help them prevent an embolic stroke. Now, on the flip side of that, if it's a hemorrhagic stroke, which is the bleeding one, that being on a blood thinner is a bad thing. But remember, we're focusing on the ischemic stroke. So the anticoagulant therapy for the AFib can help prevent the ischemic stroke. Antiplatelet therapy, statins, keeping your blood pressure under control with the antihypertensive medication. That statin is going to help lower the cholesterol and hopefully prevent the clot from cutting off the blood supply to the brain. Okay, so stroke management, the key here is prompt diagnosis. So if we think someone is having a stroke, they need to be referred to a medical center right away. Time is of the essence in diagnosing the type of stroke, and a CT scan will usually be performed, and they try to have that done very quickly after the patient with a suspected stroke arrives to the ER. A cerebral angiography may be done if they've ruled out the ischemic stroke to see what's going on with the bleeding in the brain. A lumbar puncture might be performed if the CT is negative and the intracranial pressure is not elevated, again, to try to confirm the hemorrhage or the bleeding in the brain. We'll be talking about the thrombolytic therapy in a couple more slides. You're going to want to make sure that with clients that are rule out stroke or have strokes, that we elevate the head of bed 25 to 30 degrees. You want to make sure that is because we want to keep their airway patent. We want to keep secretions from pooling in the back of the throat. Assist them with deficits depending on what the deficit is. And again, that depends on what area of the brain has the blood deficiency or dysfunction. The patients will probably be put on bed rest, and we might sedate them, but we don't want to sedate them a lot because we want to be able to assess their mental status, level of consciousness, and we don't want the sedation to mask that. They'll typically be put on oxygen, usually a nasal cannula. That's usually all they need for somebody having an ischemic stroke. And then we'll have to treat their blood pressure, try to maintain that blood pressure. We don't want it to go too high because it can, you can have insult if it's too high, and if it's too low, then the brain's not being perfused enough. So the main surgical procedure for people that have minor strokes or TIAs is a procedure called carotid endarterectomy, CEA, and this is done on patients that have been diagnosed with plaque in their carotid arteries. So whether they've been diagnosed with that via a Doppler study or an angiography, they've gone in and they see that there's plaque that is causing that carotid artery to narrow. So in order to prevent a stroke, they can perform this procedure, this CEA. And what they do is they make an incision into the artery and they excise the plaque. So they go in there, they take the plaque out, out, they sew the artery back up and then sew the skin back up. And that's obviously a major surgery because you're disrupting that blood flow to the brain, but it is a surgery that is performed quite often. Your book says that it is the most frequently performed non-cardiac vascular procedure. So you need to know as a nurse how you're going to care for clients after they have had this procedure done. One of the big nursing interventions is positioning them on the non-operative side with the head of their bed elevated 30 degrees. So if a client has the left carotid artery CEA, then you want to make sure that they are on the right side with their head of bed elevated. Maintain their head and neck alignment. You're going to avoid rotating, flexing, or hyperextending the head because that's going to put pressure on that incision and also can cause increased cranial pressure. We talked about that in the ICR main concept PowerPoint. You want to support their head when you're repositioning them and make sure you teach them to do the same after they go home, because we need to make sure that that artery and that skin has time to heal, that incision after it's been sewn back up. We want to make sure it has time to heal. Well, there are obviously complications that can come about after a CEA. One of the complications is a stroke, which is what we're doing this procedure to prevent. They can have cranial nerve injuries. There can be a possible infection. They can get a hematoma or a blood accumulation at the incision. They can have hemorrhage or respiratory distress and alterations in blood pressure. So your nursing assessments and interventions are going to be focusing on being able to identify any of those complications and act appropriately. Be aggressive in assessing and documenting a change of consciousness, a change of mental status, making sure that you're keeping their airway patent, because these patients there's going to be some edema at that incision site, and that is a normal postoperative occurrence. But you want to make sure that there's not an accumulation of the blood like a hematoma or anything that can impact that respiratory status or function of the patient, or cause more deficit, but you cause any issue with the blood flow to the brain. So another medical management to prevent stroke is carotid artery stenting. So this is used primarily in selected patients that have severe carotid artery stenosis that may not be candidates for that previous surgery we just spoke about, the CEA. And this carotid artery stenting is a procedure that's done generally in a cath lab or in an interventional radiology lab. They puncture an artery. Usually they'll do the femoral artery in the groin, and they thread a wire up to where the plaque is. So if you see diagram A here, you see that there's a wire with a basket on the top of it. They thread that wire across the plaque or that lesion. They call it a lesion. And that basket is in place so that if any pieces of the plaque break off during the procedure, it can be caught in that basket and it doesn't travel to the brain. Well, once they thread that catheter up, then in diagram B, they insert another catheter that has a balloon on it. This is what's called an angioplasty. And they insert that catheter up past that lesion, past the plaque blockage, and they inflate the balloon. And when they inflate the balloon, that plaque gets smushed up against the wall. Once that plaque once it opens up that artery a bit and that plaque is up against the wall, then they'll take the balloon out and put a stent in. So that is diagram C there. That stent is a wire mesh, and that wire mesh is going to stay in that artery forever. It actually becomes part of the artery wall. Eventually connective tissue will form over it, and it keeps that artery open. Well, in diagram D, you see after that angioplasty is in place and that artery is open, then they will remove the catheter that has the basket on it and remove that catheter from the body. And the procedure is done. So they have opened up the artery that had some stenosis. This is again called carotid artery stent or stenting. During the procedure, you as the nurse and the people performing the procedure will be monitoring the client closely, monitoring their neurologic status, monitoring their vital signs, and then post-operatively, you continue to monitor those as well as make sure that there's no bleeding. Typically, the client has to lie still for several hours, and we monitor that catheter site for any bleeding or hematoma areas. So that hematoma is a blood collection at that spot.
So with the medical management of a client in the acute phase of having a stroke, the big important takeaway here is that the patient needs to have a very prompt diagnosis and subsequent prompt treatment. You will be using the NIHSS, which stands for National Institute of Health Stroke Scale. It is listed in your Hinkle and Cheever textbook on page 2016. It's table 67.4. You'll be using that tool to assess your patient. You will make sure that you maintain their airway, patent airway, good ventilation, monitor them in their cardiac status, their hemodynamic monitoring, and neurological status. So you want to monitor their BP, you want to monitor their rhythms, you want to make sure you're doing a very good neurologic assessment. And then the next step is if it is an ischemic stroke, which is either thrombotic or embolic stroke, those are the two categories in ischemic, then it will be very important for the physicians to initiate thrombolytic therapy. It's really important for you to know here that you do not give thrombolytic therapy to a client having a hemorrhagic stroke, because that's the stroke where the brain is bleeding. So this thrombolytic therapy is a clot buster. It's going to break up the clots and hopefully help perfuse the brain in the ischemic stroke. But if someone is having the type of stroke where they're bleeding, obviously you don't want them to bleed more. It's a very potent medication. There are specific criteria we're going to go over in the next slide. Given through an IV. There are some hospitals that are stroke centers and that have very specialized units where they can give this medication directly into the artery. I think Grady is one, but typically, and how you all will probably see it, is administering this medication via IV so that we can break up the clots that are causing this deficit of blood and oxygen to the brain. Okay, it is very important that you monitor your patient for any signs and symptoms of potential bleeding. So anything that is in the patient that can cause bleeding, an IV, any other catheter, it's our responsibility as the nurse administering this and helping with the administration that we monitor your patient for bleeding. So listed here are the specific criteria for a client to receive the thrombolytic therapy, the TPA product. They have to be over 18 years of age. They have to have been diagnosed with the ischemic stroke. Again, not the hemorrhagic stroke, but the ischemic stroke, and that is done via the prompt CAT scan. We need to know what time the onset of the stroke symptoms started, because there's a strict window that we're allowed to give this medication. Typically, it's going to be within 3 hours. Your Hinkle and Cheever book will tell you that some centers push it out to 4.5 hours, but you'll need to know that within the facility that you're working. So typically, it's the 3 hours. Once that time has passed, if it has been over 3 hours that your client has started those symptoms, then they're not candidates to receive this thrombolytic because the clot has formed too firmly in the vessel, and the thrombolytic, the TPA, cannot break it up. Our clients have to have systolic blood pressures less than 185 or diastolic less than 110 because we don't want the blood pressure to be too high to cause other complications. The client cannot have had any minor stroke or rapidly resolving stroke, no seizure at onset of stroke. They can't be on any anticoagulants such as Coumadin. Their prothrombin time needs to be less than 15 seconds and the INR less than 1.7. They can't also have been receiving heparin, which is another blood thinner, in the last 48 hours. Their platelet count has to be greater than 100,000. We want them to have platelets on board so that we can make sure that if they start having excessive bleeding that they will clot. No prior issues with intracranial hemorrhaging, any neoplasm, AV formation, aneurysm. If they've had these in their history, they are not candidates for TPA. No surgery, major surgeries within the last 14 days, and then no stroke, serious brain injury, intracranial surgery within 3 months. Also, no GI or urinary bleeding within the last 21 days. So they're very strict and very specific criteria that allows a candidate to receive this thrombolytic therapy to manage the acute phase of an ischemic stroke. This is a diagram illustrating what we call the golden hour of stroke treatment. We also call it the door to needle time. And it is extremely important that all of this gets done within an hour of the patient arriving in the emergency department. So you see on the left-hand side here, the clock starts ticking as soon as the suspected stroke patient arrives into the emergency department. Within the first 10 minutes, we need to have that initial patient evaluation using that NIHSS assessment tool, and securing the airway, making sure that we have a patent airway. Obviously, we've talked about this in previous slides. They can have a potential issue with their level of consciousness, which would make their airway at risk. So initiate your evaluation, patient history, initiate the lab work and use that assessment tool within 10 minutes. The stroke team needs to be notified within 15 minutes of the patient's arrival, and a CT scan must be done within 25 minutes. You'll see the next clock there. The CT scan needs to be interpreted in less than 45 minutes, the lab's reviewed, and then determine if they're eligible for the TPA using the eligibility criteria that we just reviewed. And then if the patient is a candidate for the antithrombolytic treatment, that has to be initiated within 60 minutes, within the hour from the arrival. So it's really important that this gets done in a timely manner and gets done, very rapidly. So what you will be doing is you'll be putting probably 2 IVs in these patients, one for the thrombolytic therapy and one for the medication. So this is door to needle time, or the golden hour of stroke treatment, and it's real important that you understand this time clock and you're very rapid in your actions. The thrombolytic therapy is weight-based dosing, so it's going to matter how big your client is as far as how much of this TPA they're going to be administered or ordered. So a smaller person would get a different dosage than a larger person, and you'll learn all that. The major side effect from thrombolytic therapy is bleeding, so because of that, your nursing interventions will be to monitor all the places that have potential for bleeding. So IV insertion sites. If you've tried to get an IV in this client and you were unsuccessful, and you've made an entrance or a piercing in their skin, you need to make sure you put a compression dressing on there and you monitor that site for bleeding. The sites that have the IVs in urinary catheter sites, if they have an ET tube, you're going to monitor all the secretions, emesis, any urine, stool, monitor all those for bleeding. If you can prevent placing tubes like an NG or a Foley urinary catheter, you should avoid placing that for 24 hours after the TPA. And of course, you want to monitor for signs of intracranial bleeding, especially in our older clients. So if a patient is over 70, or if they have that NIHSS score higher than 20, if their serum glucose level is greater than 300, or if they have an edema or a mass, those are situations where you want to be super critical and super diligent in monitoring for signs of intracranial bleeding. So your nursing care for the client experiencing a stroke in that acute phase is going to be very strict and ongoing, frequent monitoring of all systems, but specifically of the vital signs and the client's neurologic state. You will be very in tune to your client's level of consciousness. So let me give you an example. Let's say that your client just received the thrombolytic therapy. So they've just received the TPA, and you are caring for the client an hour later, and your client starts complaining of nausea and vomiting, or they have a decreased level of consciousness, or their pupils are dilated. These are all indications of intracranial hemorrhage. So you have a client that has decreased level of consciousness, dilated pupils, and or nausea and vomiting. So they're exhibiting signs of intracranial hemorrhage. That's a life-threatening complication of this TPA administration. The last couple slides we talked about the monitoring the IV sites and all the different tubes for bleeding, because those are common side effects that can happen. But if you have a client that exhibits signs that they are having bleeding in their brain, then this is a life-threatening situation. So you want to make sure that you're monitoring all of their vital signs and their level of consciousness, their pupillary changes. You want to make sure that you're looking for any bleeding, you're monitoring the client's eyes and nose, of course, assessing the airway and the oxygen saturation, and maintaining the blood pressure. Remember that the blood pressure needs to stay in a pretty maintained constant rate. You don't want it too high and you don't want it too low. So your nursing care after that acute phase will be to monitor the mental status, make sure that you're checking their swallowing ability. We're going to be talking a good bit about the nutritional and hydration status, the skin integrity, checking their activity, their ball and bladder function, sensation, perception, and motor, because remember, those are all areas that are impacted when we have an intracranial regulation dysfunction. So we're going to be monitoring that and doing some nursing interventions to help the client be as optimally functioning as they can. Here are some potential problems, potential complications for a client that's recovering from an ischemic stroke. They can have decreased cerebral blood flow. Remember your brain needs adequate blood flow perfusing in order for it to function properly. And what goes along with the blood flow is the oxygen delivery to the brain. Remember, the oxygen binds with that hemoglobin, and that's how the brain is going to get the oxygen and the nutrients through the perfusion of the brain. And then lastly, pneumonia. These patients are at risk for pneumonia because for a couple reasons. One, they may be immobile. They may have issues with swallowing or aphasia, so they could be at risk for aspiration pneumonia. So these are 3 areas that we want to be aware of and monitor for. So you're going to want to focus on the whole person with your nursing interventions, not just on the brain. When someone has had a stroke, it affects the entire person. So your interventions will revolve around that. You will need to provide interventions that will prevent the complications that we just talked about and promote rehabilitation, because these patients will oftentimes have several months worth of rehabilitation. They might never get back to their normal baseline. You'll want to provide support and encouragement not only to the patient, but to the patient and the family, and then listen to the patient. And sometimes this can be very challenging, especially with patients that have expressive aphasia and they just can't get those words out. So it takes some serious patience on our part as nurses and on family members when caring for these clients. One of the interventions you will be doing with clients that have had a stroke is assisting them with nutrition. Strokes can result in dysphagia, which is difficulty swallowing. It could be due to impaired function of the mouth or any part of that upper airway there. You will have them complete a swallowing assessment. Pretty much this is done through nutritional services or speech therapy to see how likely it is that they are able to have good oral intake. So they'll be evaluated as to their ability to swallow. If their swallowing function is impaired, sometimes it'll return over time and others it won't. So we'll need to make sure that we educate the clients on alternative swallowing techniques. So telling them to take smaller bites of food, making sure that they maybe are started on a thick liquid or pureed diet, because these foods are easier to swallow than thin liquids. Encourage the patients to sit upright, preferably out of bed in a chair, and instruct them to tuck their chin towards their chest as they swallow, and that'll help them prevent aspiration. Their diet may be eventually advanced as they become better at swallowing. And if they're impaired enough or have a big enough deficit, they may require tube feedings, enteral tube feedings such as nasogastric or gastric gastrostomy tubes. But the goal is to prevent aspiration, and the nursing diagnosis is impaired swallowing. One of the nursing interventions, or several nursing interventions you will be completing for patients with strokes are in the area of improving mobility and preventing joint deformity. So if a patient has hemiplegia, which is that unilateral paralysis on one side of their body, or hemiparesis, which is the weakness on one side of their body, then they will need some assistive devices. They will need some help in improving their mobility and preventing joint deformity. Okay, so what that will entail will be correct positioning, turning and positioning them every 2 hours, preventing contractures. You need to relieve pressure on and make sure their body is good and aligned when they're lying down. Oftentimes these folks will need splints of some sort to prevent the contractures. I have a picture here of an arm splint. The elbow and wrist tend to flex and the legs tend to rotate externally. So we're going to make sure that when they are in this situation, we're assisting them in good body alignment. We want to make sure that they receive passive or active range of motion 4 or 5 times a day. So that's actually getting their body, their limbs, all their extremities in motion to prevent the contractures. A A lot of times clients that have had the hemiplegia or hemiparesis, they will have a flaccid shoulder. Their arm will just go limp. We need to treat these problems, prevent further issues, and hopefully help them, if possible, increase their mobility, increase the strength in these extremities through our interventions. Take note that individuals who have sustained a stroke and have issue with mobility will also have pain and potential issue with their skin integrity. We want to make sure that our clients are encouraged to exercise that unaffected side as well. Make sure that we establish regular exercise routines for them. They will need assistance possibly in getting out of bed and hopefully progressing to ambulation. So this picture here is an example of a healthcare provider helping a client in standing, because what happens is you need to progress to standing and then ambulating. And making sure that we do this safely. They use things such as tilt tables to help clients that have been in bed or immobile for a long period of time. They also may need wheelchairs, perhaps those three-pronged walkers when they get to that point, but they will need some mobility aids, transfer devices, transfer boards, gait belts to help them with ambulation. So in the area of enhancing the client's self-care, we want to promote achievement of self-care as much as possible. We want to have realistic goals. As soon as they can sit up, we want to encourage them to participate in their personal hygiene activities. The first step is to carry out all self-care activities on that unaffected side, because remember, if they have the hemiparesis or hemiplegia, they will have the one side that is a lot weaker or paralyzed than the other side. So we'll want to make sure that we have them comb their hair, brush their teeth, that type of thing, with the hand that they're able to use, their unaffected side. This may be awkward for them, especially if they're right-handed and their deficit is in their right hand, but it can be learned with repetition, and eventually that unaffected side will become stronger, hopefully. But it can be frustrating with these clients, so we need to make sure that we provide them with the assistive devices or tools that they need to be successful. I have a picture here of a device that helps the client slide on their socks. I actually used one of these after I had a lumbar fusion, and they actually work really well. But in your textbook in page 2021, there's several assistive devices that enhance self-care after a stroke. And I encourage that you help your clients set realistic goals, help them get these devices, and encourage and support them as best you can. We will need to, I think one of the next slides is verbal communication. When a client has issues with communication, we want to use strategies to enhance that, and we'll talk about that in the next slide. But in self-care deficits and as well as communication, the patient needs to be encouraged to turn their head and look to the side with that visual field loss, because a lot of times they'll try to avoid that. So that is an area that we want to assist them in. So in the area of improving communication, our goal for our clients would be to achieve a form of communication. So strokes, remember, can result in aphasia, which impairs the patient's ability to express himself and to understand what's being said. And I had a list of a bunch of different aphasia areas and what that looks like. But in general nursing intervention terms. You want to make sure that when you speak with the client, you face the client and establish good eye contact. You speak in a usual manner and tone. Use short phrases. Take time to pause when you're speaking to them to make sure that the client understands what you're saying. If you're able to, try to limit conversation to practical and concrete matters. Use gestures, use pictures. I have an example of a communication board over here. I cared for a client at the VA one time that used one of these communication boards, and it was extremely helpful. They were able to answer yes, no questions with the board with their unaffected side. We'll be working with speech therapy to assess communication needs of the patient after they've had a stroke, and then help them improve the communication, because obviously it can be very frustrating with your client if they are unable to communicate like they were prior to the stroke. After a stroke, the patients can have issues with urinary incontinence. This can be due to their inability to communicate that they need to use the restroom. It could be their inability to hold a urinal or to actually sit in a position that will facilitate urination. Sometimes the bladder can be atonic, where there's impaired sensation to the bladder filling. So there can be issues with both incontinence, or you can have bladder retention, where the clients need to be straight catheterized to get the urine out of the bladder. They can have issues with their bowel pattern as well. Sometimes they can become bowel incontinent or stool incontinent, or they can have issues with constipation. To facilitate the constipation issue, unless it's contraindicated, we want to encourage these clients to have a high fiber diet and have adequate fluid intake. And we want to provide them with regular time for toiletry, set up a schedule for both urination and for bowel and bladder retraining. So schedule for urination and bladder and bowel times to use the restroom. Remember also, these clients typically are not getting as much activity, so that can also aid in that constipation. So we want to promote continence of bowel and bladder as our goal for the urinary incontinence and constipation diagnosis. Educating the patients about self-care, the patients and the family, is really a fundamental component of the stroke recovery. The nurse provides education about the stroke, its causes, its prevention, its rehabilitation process, so that there are realistic expectations that the family and the client have it for their recovery period. This will more than likely entail using some type of assistive devices, modifying the home environment, whether that means that they have to get a ramp in to facilitate a wheelchair, or they have to put handrails in place along the bathtub to prevent them from falling, because remember, they are going home probably more than likely with deficits in their mobility, and they're unable to move as well as they could prior to the stroke. We're going to want to make sure that the clients and their families know what the signs and symptoms are for the complications that we talked about in the last couple slides, with cerebral perfusion and oxygenation to the brain and possible pneumonia. So they need to be aware of how they prevent those complications. If they're on medications that require frequent lab draws, if they're on some blood thinners, we need to educate them on their medication, and We talked a good bit about nutrition and the swallowing techniques and the bowel and bladder programs. All of that is very important to not only not only intervene while they're in the hospital, but when they go home, we need to educate the client and the patient to continue these interventions when they get home. And lastly, the whole idea about getting these clients in some programs that will help them exercise, get them some recreation, hopefully with some diversion from their deficits, get them into support groups, give them community resources so that they can improve the quality of life after the post stroke, after they are recovering at home from the stroke. Here is the same interrelated concept slide that I had for the intracranial regulation concept. I hope you have enjoyed this PowerPoint on stroke, and the next PowerPoint that I will be uploading will be the one on seizures. Thank you. Let me know if you have questions.